Hi, my name is Katie Wiskar from IVC POCUS, and in today's video we're going to be talking about IVC ultrasound. So our goals for today's screencast: first off, we're going to briefly touch on some IVC anatomy. Then we'll talk about CVP, or central venous pressure, because you can't talk about the IVC without understanding CVP. We'll talk about how to practically scan the IVC and a couple different approaches for this. And next, we'll talk about asking the IVC the right questions so that we can actually get useful clinical information from it. Finally, we'll touch on some common caveats and pitfalls when it comes to IVC ultrasound. Now, please note, this is not meant to be an exhaustive review of everything to do with the IVC. If you want more detail, I really encourage you to check out the 60-minute video from my colleague, Dr. Shane Arishinkoff, on the IVC POCUS site, all about the IVC and the physiology and the evidence behind it. I also highly encourage you to check out our 20-minute volume status primer, because that's really related to a lot of the stuff we're going to talk about today, and especially a lot of the misconceptions that relate to the IVC. So on that note, right off the bat, before we start, there is a very common misconception that the IVC will tell you the patient's volume status. And if you take nothing else away from this screencast, please understand the IVC is not a marker of volume status. Volume status is highly complex, and again, please check out that dedicated video. But the IVC, nor any single measure, cannot tell you a patient's volume status and cannot tell you whether or not you should give a patient fluid. It is one data point, and we're going to talk about how to properly acquire that data point and how to use it correctly, but it is not a single answer to some mythical volume status question. So first, let's quickly review the anatomy of the IVC. So this is a helpful diagram that shows different parts of the IVC. And we just want to remember that with POCUS, we are scanning the intra-hepatic part of the IVC, which is shown here in purple. And we can see it insert into the right atrium, and note that it does that right at the level of the diaphragm. And we can see the hepatic veins drain into the IVC, which enter just before the RA caval junction. Now, you can't talk about the IVC without talking about CVP, central venous pressure. So CVP is defined as the pressure in the central veins, aka the vena cava. And we can use ultrasound features of the IVC, its size, its shape, its collapsibility, which we'll talk about, to help us infer CVP. So this is what the IVC is telling us. The IVC tells us CVP. It doesn't tell us volume status, it tells us CVP. Now, we hope to have a dedicated video on this in future, but I'd be remiss not to quickly mention here a couple of commonly misunderstood points about CVP. So firstly, and most importantly, CVP is a pressure, and we often use CVP to infer volume, but clearly other non-volume related things can affect CVP. A really classic example here is pulmonary embolism or tamponade. Neither of these things are volume problems, but they will lead to a high CVP, which will be reflected in the IVC. Next, CVP can tell us about things upstream, so the peripheral venous system, and downstream, the right heart. And remember that the venous return to the right heart is governed by that small gradient between the peripheral venous system and CVP. And if CVP rises, so too must peripheral venous pressures, which leads to systemic venous congestion. Lastly, and this is so important to emphasize, a normal CVP is a non-elevated CVP. So a normal IVC is a non-plethoric IVC. The job of the right heart is to keep filling pressures low. This is the normal physiologic state. Okay, so let's get into the nuts and bolts of how to scan the IVC. There are a few options here, as we'll see in the next slide. Now, generally speaking, you're going to want your patient supine, often with their knees bent, as this can help relax the abdominal musculature. In all of our views, we're going to be using the liver as an acoustic window because ultrasound beams travel very well through the liver. And we are also going to want to obtain multiple views of the IVC, specifically both short axis and long axis views, as this will give us the most complete information. As I mentioned, we have options when scanning the IVC, and it's actually really helpful to be familiar with several approaches, as different patients may have different windows that are more accessible. So essentially here, you're going to pick one from each column. You can use your phased array or your curvilinear probe. You can approach from either a subcostal or a transhepatic, sometimes called a coronal or rescue approach. And you can scan in either the long or the short axis. And in fact, we highly encourage you to do both. So let's go through basic technique for each of these approaches. starting with what is probably the most familiar approach to most people, a subcostal approach with a long axis view. So as mentioned, you can use either the curvilinear or the phased array probe here. Many beginners like the simplicity of the curvilinear probe, and that's great. Personally, I find that sometimes the phased array can often nestle in a little bit closer to the xiphoid process, allowing a better view, but I encourage you to play around with both options. Now, before you start, I always suggest palpating the xiphoid process as your external landmark, because the key here is to place your probe, so let's assume we have the curvilinear probe, in the abdominal preset, in a sagittal plane right underneath the xiphoid process, as close as we can get there, with the indicator pointing towards the patient's head. And we really do want to nestle right under that xiphoid process, because if anything gets in between our ultrasound probe and the liver, which is our acoustic window, so bowel gas, for example, that's going to obscure our view. Now, if you place your probe on here with your ultrasound beam pointing directly downwards at this point, you probably will have a view of the patient's aorta, which lies in midline, and perhaps a little bit of the liver, perhaps some obscuring with bowel gas. From here, the two probe movements that will bring the IVC into view are to slide your probe towards patient right along the costal margin. You can also actually do this with fanning of your beam to the right in thin patients. This will allow the IVC to pop into view, which lies to the patient's right side. And next, you're going to gently rock your probe so that the beam of your probe is pointing more up into the chest, which will allow you to see the RA caval junction. So your image should therefore look like this. So we see the transhepatic IVC, so the portion of the IVC that's running through the liver. We see the hepatic vein emptying into the IVC, and we see the IVC joining the right atrium. And to confirm that the tubular anechoic structure we're seeing really is the IVC, we always want to see those three landmarks. So the IVC, the hepatic vein, and the right atrium. Now, we also want to make sure that we're seeing nice, crisp, hyperechoic borders of the IVC, because this is a good clue that we're seeing the IVC in its maximal diameter, and we're not cutting it off and underestimating its size due to the cylinder effect. As a quick note, I mentioned earlier that we typically use the abdominal preset to scan the IVC. If you're using the phased array probe, you may also choose to scan it on the cardiac preset, and this is often done at the conclusion of a cardiac scan, moving directly from a subcostal 4-chamber view of the heart to a long axis IVC view. So this is achieved by rotating your probe 90 degrees. So in cardiac convention, you'd go from having the probe indicator pointing to 3 o'clock for your subcostal 4-chamber view to 12 o'clock for an IVC view. And this technique is sometimes preferable for more experienced operators, as it allows you to keep the right atrium in view the entire time, but it does take a little bit of getting used to. Okay, so that was our long axis view, which is usually the most familiar to people. However, we always want to scan things in 2 planes, so we're also going to look at the IVC in short axis. And we'll talk about what extra information this gives us in a second. So the technique here is relatively simple. From our long axis view, we're simply going to rotate our probe 90 degrees so that we're now scanning in a transverse plane. Now, technically, if we've used the curvilinear probe on the abdominal preset, we're going to rotate our probe so that our indicator is pointing towards patient right. If we've used the phased array probe on the cardiac preset, because the cardiac preset is flipped, we're going to rotate our probe so that the indicator is pointing towards patient left, or 3 o'clock. But really, if you get this wrong, it's not a big deal. Your image will be flipped, but still totally interpretable. Now, what we're looking for after we've done our rotation is this short axis view. So we should see the bright echogenic spine with shadowing beneath it at the bottom of our screen. We should see a round hypoechoic structure that is the aorta, slightly to the right of the spine. And then we should see the transhepatic portion of the IVC in short axis on screen left, with the hepatic veins approaching it to drain into it. And now what we want to do with a little bit of fanning of our probe is follow that short axis IVC all the way up to the right atrium and then down past the insertion of the hepatic veins. And we'll see shortly that the point at which we want to assess the IVC is typically just past the insertion of the hepatic veins. So that was the subcostal approach. As an alternative, if that is unavailable, such as in patients with midline scars, significant bowel gas, tense ascites, that kind of thing, a lateral transhepatic approach can be very helpful. So this is sometimes also called the coronal approach or the rescue view. Now, as the name would suggest, you're going to place your probe in a coronal plane in the mid-axillary line around the level of the xiphoid process, with the indicator pointing up towards the patient's head. And typically I do suggest the curvilinear probe on the abdominal preset for this approach. Now this probably looks familiar for those of you who are used to doing lung ultrasound to look at the lung bases, or even a right upper quadrant fast view. This is the same starting point. Now sometimes the IVC will pop directly into your view when you place your probe here, which is great. And if not, the move to employ is generally a little bit of fanning or sliding in the anterior-posterior plane. For example, if you can see spine and kidney in your view, your beam is directed to posteriorly. So you can try sliding your probe a little bit anteriorly until your long axis IVC pops into view. So this is what this will look like. So often it is harder to see the right atrium from this view, but you should still be able to see hepatic veins feeding into the IVC. Now note that this view can take a bit of manipulating around the ribs to avoid rib shadows. Sometimes moving down a rib space or employing some mild rotation can help get those pesky ribs out of the way. Now, one important caveat with this view, so the IVC literature almost exclusively looks at the subcostal approach when it comes to data like diameter, which we'll talk about in a second. However, we know that most IVCs, which are elliptical in nature, are larger in AP diameter than they are in width. So if we only look at a transhepatic long axis view, we can actually overestimate size. So that's not to say that this approach isn't helpful, but if you're using this approach, it's extra important to try to get a short axis view to corroborate your findings. So on that note, here is our short axis view. So once again, obtaining this view is relatively simple. From your long axis transhepatic view, you're simply going to rotate your probe 90 degrees so that your probe indicator is pointing up towards the ceiling. And you can then use fanning to assess the IVC over several centimeters, as we did before. So now that we know how to physically scan the IVC, let's talk about what data points we can interpret. So there are 3 points to consider: IVC size, IVC collapsibility, and IVC shape. And let's go through each one in turn. Firstly, IVC size. So here we mean two-dimensional diameter, typically measured in the long axis. So recall again that what we're trying to determine with the IVC is a rough estimate of CVP, and specifically whether CVP is pathologically elevated. Now, cutoffs in the literature for what IVC size correlates best to an elevated CVP vary, and it's really essential to recognize that this is a parameter that is most useful at extremes, and our test characteristics, so the sensitivity and specificity of the IVC for a high CVP, will vary depending on where you place your arbitrary cutoff value. So we tend to use a cutoff of 2 centimeters, recognizing that this is not standardized for body surface area and that this is only one parameter. So an IVC of 3.5 centimeters is much more likely to be associated with a high CVP than an IVC of 2.01 centimeters, for example. Technique-wise, in terms of where to measure with your calipers, most of the literature supports about 3 to 5 centimeters from the RA caval junction, which ends up being 1 to 2 centimeters after the hepatic vein insertion. And note that we do not want to measure right at the RA caval junction at the level of the diaphragm for reasons we'll discuss shortly. Next, let's talk about IVC collapsibility. So note that this discussion is relevant to spontaneously breathing patients. In passively mechanically ventilated patients, we would be looking at IVC distension with inspiration rather than collapse. So when we talk about collapsibility, we're talking about a change in AP diameter, usually measured as maximum versus minimum divided by maximum, with inspiration. Now, you can measure this with calipers or with M-mode, though I prefer to eyeball this from a regular 2D clip, and I'll explain why in a second. In terms of our cutoffs, for spontaneously breathing patients, generally we use a cutoff of 50% collapsibility, though again, this is not a dichotomous measure. This parameter is most useful at extremes, which is part of why I prefer to eyeball this rather than measure it. Because 45% collapse versus 55% collapse shouldn't make a meaningful clinical difference to you, and you can easily eyeball whether an IVC is collapsing 10% versus 90%, for example, with respiration. Now note here that there is a big caveat with regards to respiratory effort, and we'll talk more about this shortly. In terms of how to actually assess this, my practice is first to watch patients with quiet breathing, and if the IVC collapses even just with quiet respiration, then that is quite convincing for a non-elevated CVP. If it is not collapsing with this, then I'll ask my patients to do a small sniff, which is supported in the literature. And once again, as a reminder, we're not discussing passively ventilated patients here. For those who are interested, the cutoff for distensibility is 18%, which is a bit harder to eyeball and so is often measured with M mode. Okay, so the last IVC parameter that we can assess is shape, which is arguably the most reliable. So there's data showing that IVC sphericity, so how circular the IVC is as opposed to being ellipsoid, correlates better to an elevated CVP than diameter or collapsibility alone. This parameter also has the benefit of not being confounded by variations in body size, for example. Practically, assessing shape is easily done in a short axis view. Now you can measure a sphericity index if you really want to, but I suggest again just eyeballing this. As with all IVC parameters, this is most useful at extremes. But here, for example, you can clearly see the difference between an IVC that is very ellipsoid in shape on the left versus one that is round and circular and plethoric on screen right. Okay, so we know how to obtain images of the IVC and which data points to assess. But what can the IVC tell us clinically? So this is where many people go wrong. Again, the IVC cannot tell you what the patient's volume status is, nor can it tell you whether or not you should give the patient fluids. Recall once again that the IVC tells us the CVP, and the CVP is pressure, not volume, even though we often infer the latter. If we think about it another way, the IVC is generally most useful to answer questions about things that are directly upstream or downstream from it, so the right heart and the peripheral venous system. Now let's go through some common clinical examples. Starting off with fluid responsiveness. So this is a very common temptation to try to use the IVC as a gauge for potential fluid responsiveness, but really we should know better than to expect the IVC to be able to tell us this. We know that CVP is not great for fluid responsiveness, so the IVC is also not great for this, and the literature here is really lukewarm. So I suggest avoiding trying to use the IVC to predict fluid responsiveness. On the other hand, the IVC can be much more useful for fluid tolerance, so that is, assessing for the potential harms of additional fluid administration. And remember that the job of the right heart is to keep filling pressures low, so elevated filling pressures, a high CVP or a plethoric IVC, are an indication of some pathology. And the first and necessary step to right-sided organ congestion is an elevated CVP, so the IVC can often serve as a useful warning sign here. Now, what about hypoxia? So we will commonly look at the IVC and JVP in patients with hypoxia and suspected heart failure. And while the IVC can be somewhat useful here, remember that the IVC, so CVP, is a right-sided measurement, and pulmonary edema is a left-sided problem. And while heart failure is often congruent, so there is both right and left-sided overload together, it is not always. So a thorough lung assessment, as well as just a recognition of the varied phenotypes of heart failure, is really essential here. And lastly, the hemodynamic AKI, and in particular, congestive nephropathy. So as with fluid tolerance, an elevated CVP, so a plethoric IVC, is a useful first step and is a prerequisite for clinically significant organ congestion. So a plethoric IVC cannot make this diagnosis alone, however, it's not specific enough for that, but it's highly sensitive, so it's a good place to start for this. All right, lastly, let's touch on a few common pitfalls and caveats with IVC scanning. First is the classic IVC versus aorta. So we've all mistaken an aorta for an IVC at least once. In addition to your systematic scanning approach that we talked about earlier, other clues that can help you are that the aorta will always be to patient left compared to the IVC. The aorta will appear as more vertical and straighter in long axis. It will appear pulsatile with thicker walls, and you'll see the bright hyperechoic spine beneath it. You also won't see it enter the right atrium, nor will you see hepatic veins drain into it. And if you're not sure what structure you're seeing, I always suggest fanning or sliding back and forth in the long axis, and the IVC will always lie to patient right. The next common pitfall is assessing the IVC right at the diaphragm. So the diaphragm can either tent the IVC open or pinch it shut with respiration. So to avoid being fooled by diaphragmatic mechanics, remember that we want to make our IVC assessment 1 to 2 centimeters distal to the hepatic vein insertion, and this holds true for both long and short axis views. Another really common pitfall is false collapse. So in a long axis view, we can sometimes think that we're seeing the IVC collapse with inspiration, when really it's just translating laterally or moving out of our plane of view with respiration. And one clue that this may be occurring is that you're losing your nice crisp IVC borders, as we see here. So a great check for this again is to scan the IVC in short axis, as this will let us know if the IVC is truly changing with respiration or simply moving laterally. Next, and hopefully I've emphasized this point throughout this talk, is looking in only one view or using only one parameter. So like all things in POCUS and in medicine, more data points is always better, as there's caveats to each one. So always scan in more than one view and pay attention to multiple parameters when making your assessment. This next one is often ignored but is so important: respiratory mechanics and effort. So IVC collapsibility occurs due to changes in intrathoracic and intra-abdominal pressure during respiration, and so the magnitude of those pressure swings really matters. There's good data to show that with significant pressure swings, so high levels of respiratory effort, that even people with very elevated CVPs can collapse their IVC. So those patients who are working really hard to breathe, IVC collapsibility becomes much less reliable. And furthermore, any patient who's receiving a mix of positive pressure and negative pressure ventilation, so patients on BiPAP or CPAP or pressure-supported ventilation modes, IVC collapsibility really becomes a wash and is very difficult to interpret. Likewise, ignoring intra-abdominal factors can also lead to misinterpretation. So here we're particularly thinking of conditions which lead to elevated intra-abdominal pressure, such as abdominal masses or tense ascites, which can compress the IVC and lead you to underestimate the CVP via this avenue. I've said it a few times in this video, but the IVC is most useful at extremes. This is not a dichotomous test. And you really want to avoid the temptation to try to categorize every IVC into one of two boxes. A lot of IVCs will really be in that gray zone and shouldn't really impact what you do. So resist the urge to try to overinterpret these. Lastly, don't overestimate what the IVC can do. It cannot answer all of your volume-related questions. It is one data point, and you want to integrate it with all of your other POCUS and clinical data points. All right, so here's our recap about how to scan the IVC correctly. Number one, understand what the IVC is telling you. So the IVC tells you the CVP, which is a pressure from which we can infer things about volume. Number two, we're going to scan the IVC correctly, and it pays here to have a few different tricks up your sleeve because every patient may have different accessible windows. Number three, we're going to ask the IVC the right clinical question, and we're not going to overestimate what the IVC can tell us. Number four, be aware of some of the pitfalls and caveats here, both technique-wise as well as with clinical interpretation. And number five, as always, we're going to integrate the IVC with all of our other clinical parameters, and we're not going to solely rely on a single measure to tell us volume status. All right, that's everything for today. I hope you enjoyed this. Again, I really encourage you to check out the volume status primer if you found some of this useful, and the more detailed 60-minute video for a full review, including some of the evidence behind all this. Thanks for watching and happy scanning.